And today we are extremely overwhelmed and pleased to have an eminent teacher who is an expert in endocrinology, and he's a well-known figure in the field of ART, Dr. Sachin Kulkarni, sir. Can I have his CV, Sindhu, please? So just to have a glimpse of our previous master classes, which we had a series of masterclass in embryology, which was dealt with eminent speakers based on fertilization and all about IVF, implantation. And, we did our last masterclass with Dr. Gaurav Majumdar, who dealt with about IVF. And, it was really a wonderful lecture. And the previous masterclass on ART was on recurrent implantation failure, which was dealt with by Dr. Sanjeev Reddy. And our next masterclass in embryology is going to be about embryo quality assessment techniques, variations, and beyond, which is going to be on 8th of May, 2025. And today's masterclass is going to be done by Dr. Sachin Kulkarni, sir. He's a consultant at Sunanda IVF, Kolhapur. He's the head of the Department of Fertility and Reproductive Medicine, department at Jahangir Hospital, Pune. He's a teacher of all teachers, and I think he requires no introduction to all the delegates over here. He has got numerous presentations and publications. He's also running a regular fellowship program and actively training a lot of postgraduates in the field of reproductive medicine. And today, sir is going to take us through this complex topic of stimulated cycles and endocrinology of stimulated cycles. And this is going to be a part 1 because the whole thing cannot be dealt in one masterclass. So we are going to be having a subsequent part 2 to this class on 22nd of May, 2025. I request Dr. Sachin Kulkarni, sir, to please kindly take over this session. And I request all the delegates to please actively ask all your questions, be it simple or complex. Let us all, learn and, revise our knowledge in ART to give better outcomes. Thank you so much, sir, for accepting and coming to this.
Thank you, Dr. Vasundara. Thank you so much. And thank you so much to the SCALE team for enthusiastically organizing this. And I really adore and applaud your attitude of organizing such academic meetings and putting everybody on the same stage so that we can discuss aloud about all our troubleshoots. I think many of the conferences with 15-minute short lectures do not allow us that kind of a flexibility. And this is such a unique platform you have developed, and really hats off to you that this flexibility of questioning our science is so important. If you go back to our historic days, like when we were in schools, we used to read stories about Mahabharata and kings and queens, and they would say the Rajaputra was very good and he won the debates against people, and that's the way we learned in our mythology. So I think that is something which we should not miss on. We should debate with each other very healthily so that we learn more, and at the end of it, our ethos is to benefit the client sitting in front of us. So allow me to share the screen here. Are you able to see my screen? Okay. Before we start off, firstly, this is definitely an exhaustive topic. I've just tried my best, and with the help of Dr. Shariu, to put it in a very concise fashion into this presentation. And we will be today discussing some aspects of endocrine monitoring. Is the screen still seen?
So we can't see the presentation now.
1 minute. Yeah. Now you can see?
Yeah, now we can see.
Yeah.
Is the video bothering you? Is there a video of ours coming there in your screen?
What is coming?
No, are you able to see the full screen?
Can you minimize that video icon, sir? So
yes, ma'am.
It's the full screen.
Yeah, I'm able to see myself properly, not issue. In a sense, I can see the screen myself mostly. The screen is visible, am I right?
No, sir. In the screen, in the top right corner, we can see ourselves actually. So,
Oh, yeah, gone.
yeah, yes, sir, yes, sir.
Even that is seen to you. Okay, fine. Fine. So I've just asked a question to ourselves that is endocrine monitoring in an ART cycle necessary, and does it really help? And there were a lot of earlier papers, maybe a decade back, which came basically from Australia because the distances are very high. Whether ultrasound monitoring alone could be enough for ART cycles. Obviously, those days everybody was using long agonist protocols. So we'll asking this question. We will just try and go through the whole IVF protocol and stimulation, and let's see how we understand it with the endocrinology in place there. So what are the real world practices? We definitely do hormonal monitoring. All of us do, and this is a nice paper published in 2023. Is that majority of the ART specialists consider hormonal monitoring as essential, and 80% across the globe use it for with sonography. 87% of gonadotropin dose adjustments during the ovarian stimulation, with 61.7% adjusting based on the hormonal level setup. So hormone monitoring, everybody is uniformly doing it. Estradiol is most frequently monitored and used by almost 74% for OHSS prediction. And 1/3 of respondents in this particular worldwide survey say that they measured LH during all the visits. And dose modifications and addition of LH decisions, all that depended upon what was the hormonal profile during the course of stimulation. They took the call accordingly. Cochrane and Ashray, they say that USG alone is adequate for IVF cycle monitoring. But can this be a universal practice? Well, there is a consensus amongst all IVF clinics that we all do hormonal monitoring. We can't be doing only ultrasound, not doing any hormonal test. And then if the client fails, it may be a sign of negligence from the doctor's part. It's a consensus-based practice. We do value-based and consensus-based. So I think hormonal monitoring of an IVF cycle is consensus-based as well as value-based. Patients with hypoc IVF stimulation, well, you need a very thorough endocrinological monitoring. Extreme low reserve stimulation is also your decision making. Many times are done early, and that will be guided by the hormone monitoring. You have to have some set criteria for cycle cancellations. Again, hormonal monitoring will be very essential, and analyzing Posidone modes. But suppose because Posidone 1 is a retrospective diagnosis, if you come across a lady with Posidone 1, how would you analyze what corrections are needed in this particular case in the next cycle when you're planning it? And that analysis will be quite complete if you have the hormonal monitoring reports with you. So the key agenda is we're going to look at your hormones on the start date. We're looking at the day 6 of stimulation. We will look at the day of trigger and measuring trigger. This is the topics which we cover. I'm again telling you that there would be a few things which will be left aside. And I'm sure you can add to my stories. You can just comment it up and we'll try to cover in our part 2 as well. When we start the stimulation, there has been a long time, last 2 decades, have seen that day 2 stimulations have been common. But lately, over last 5 to 6 years, random starts are becoming commoner and commoner. Earlier, random starts were restricted to people who are traveling abroad or people who are doing onco-fertility. But knowing the benefits of random start, and most of our colleagues and everybody is moving towards random start. I would say, rather than using the word random start, it just means that randomly the client comes and you start. No, it never happens that way. We take a very judicious decision by doing something called follicular tracking or AFC tracking. And when we feel that AFC is synchronized naturally or because of our treatment, and when we feel there is an adequate AFC and for the given AMH and the given age of that particular lady, that's the time we start stimulation. That's what we call a random start. So random is not absolutely a random thing. It's a very concise decision, which is a very thoughtful decision. We take a start. It's only random to the day of menstrual cycle. So we need to know the start day hormonal profile. Don't go by the complexity, let me just explain. So these are various situations where you will start your stimulation. Either you will start between the first follicular phase, let's say day 1 to day 40. You would start your stimulation in the early luteal phase, or you may start your stimulation in the late luteal phase. So that just put it simply, the day 1 to 14, 14 to 21, 21 later on. So suppose the client comes on day 1 or day 2. What is it? You should have an estradiol level less than 60. LH, FSH will be normal as per her age, etc. Whatever criteria are. A 60 picogram and less estradiol means you don't have basically both your ovaries are quiet and your pituitary ovarian axis itself is also quiet. Sometimes, especially women with advanced age or women who have a low ovarian reserve, the luteofollicular transition, instead of starting on -3 days, can start on -7 or -8 days. So by the time day 2 come, you could have a follicle which is about 12 to 13 millimeter, and that could already secreting estradiol, and the estrogen level could be high at this place. But it doesn't make a difference. Even if the estrogen is high, only one of the follicles is 12, 13, 14 millimeter, you can still start the stimulation. It's not going to affect your whole stimulation protocol. Neither it will affect your decision for fresh embryo transfer or frozen embryo transfer, because your exogenous HMGs or FSH, what you're giving, is going to push the further growth of the follicles in this particular case. We'll also discuss what happens if one follicle only comes up later. We'll discuss that at a later point. Let's understand the basics first. Second, lady could be seeing you beyond 8 days, or she could be seeing in the late follicular phase. What would be there? It would be a follicle which is dominant. So beyond 14 millimeter, estrogen will be higher, there will be high inhibin, and LH, FSH both will be higher, and then the surge is going to take place in some more time. And this is particular situation. If a client comes, I don't start my stimulation at this point. But what I prefer in my clinical practice is to give an injection leuprolide. So I'll just give a decapeptyl or leuprolide, just one dose, that will cause like a GnRH surge. So it will be an LH surge, and that will be followed by active luteolysis. And 72 hours after the trigger, I'll call the patient back. The follicle would have ruptured by then, and even the hormonal profile would have quieted down, because in 72 hours, because of active luteolysis, your progesterone has come down, the corpus luteum is going to go down, and you can start off your stimulation. So I don't generally start stimulation at this point, because what I fear is if you start the stimulation with a dominant follicle already around in the late follicular phase, there could be a LH surge can take place because of that particular follicle. Actually, it doesn't make much of a difference, because that will rupture, and if the other follicles are less than 10 millimeters, they hardly have any LH receptors. That LH surge is not going to affect them, and you can still rescue the follicles. But I think most of us are not tuned to that kind of a stimulation protocol, so I prefer doing it the rupture and then going ahead. Second, a client would come to me in the early luteal phase, where there is a corpus luteum, a functional corpus luteum is available, where the progesterone is high. Progesterone high is very good, because of the progesterone is high, there is your GnRH pulsatility has come down. Though I have written LH predominant, don't go by the word predominant, the LH is there, it is on a fall. The LH is going to go down slowly with the mid-luteal phase onward. The LH will start going down. It's only the LH will last there only for about, let's say, 24 hours or 36 hours, then the LH will start coming down. And FSH should be normal. At this point also, you can start the stimulation because it is a very safe point. And generally, the premature luteinization does not take place. If you start a stimulation, you can even call the client after 8 days or 9 days of stimulation, because unless she crosses over the menstrual cycle, because the risk of premature luteinization is not there, and you can safely start the stimulation at this point. I have one issue here. Look at the follicle sizes. I have particularly drawn 3 follicles, 3 follicles on the right side. They're bigger, just one above the blue round of corpus luteum on both sides. And the 4 of them are smaller. These 3 are actually recruited follicles when in the follicular phase, but they never went to ovulation. The one went to ovulation is now a corpus luteum, but these recruited follicles are now becoming atretic. When the atresia sets in, these follicles are going to regress slowly. So you will have some follicles who are less than 10 millimeter, between 7, 8, 9 millimeter. And you will count them as AFC, but actually it is not an AFC which is going to contribute to your dominant follicle at the end of stimulation. These are atretic follicles. Even if you rescue them, they're not going to get you anything there, or you may not be able to rescue them also, because atretic follicles cannot be rescued after about 72 hours or so. So even if thinking that this AFC is good, 7, let me start stimulation. At the end of 5 or 6 days, you'll realize only the 4 follicles are growing, the rest 3 have become atretic as it is. But when you come to the late luteal phase, you will have typically your luteofollicular transition is taking place -3 to -7 days, depending upon the age and the ovarian reserve, and you would have more good synchrony follicle. Your progesterone will be low, estrogen will be low, FSH, LH low, and probably this is the right time to kick off a stimulation. So today in my practice, about most of my patients would be starting the stimulation at this point. If you want to do a random start practice in others, firstly, in the very first consultation, you must explain them that your menstrual cycle is different and your ovarian cycle is different. And we are not interested in your menstrual cycle. We are only interested in your ovarian cycle, because we need eggs. We'll be interested in a menstrual cycle only when we do an embryo transfer. Since my plan is not to do a fresh embryo transfer cycle, I can very well make this utility. If it is a fresh embryo transfer cycle, yes, random starts are less. More likely, you would like to start a stimulation in a very late luteal or early luteal phase of day 2 or day 1 of the stimulation itself. What about the pre-treatment? Can pre-treatment have an effect on the hormonal profile on day 2? I've looked into 3 pre-treatments: the combined oral contraceptive pills, estradiol, and agonist antagonists. I think we have churned enough of the combined oral contraceptive pills, and I do remember a very early paper by Sachin Kulkarni, which talked about giving combined oral contraceptive pill is going to get you a low live birth rate. Well, you're going to have more miscarriages. Fresh embryo transfer is no, and it can even affect the miscarriage rate in the frozen embryo thaw cycle, etc. But all that has vanished slowly after the Spanish study which came by Garcia Velasco, because the earlier studies had different amount of estrogens in it. It was given for varied period of time. And you know something why COCs ever came? Because I think in the European world, the Belgium world, and that is the part where the IVF became very predominant. And a lot of these consultants would go out to Cyprus and Macau and places like this to do batch IVFs. And all those patients were synchronized with COC. And that's how then once probably they might have realized that the ones treated with COC have a low rate success compared to the other ones. And those were the days of fresh embryo transfer cycle. So we started churning out the data and the effects of COC pre-treatment. But what we came out of the information, you go through a paper by George Grissinger on the science or the result is in the data itself. A nice paper is presented on COC. Very old paper. The Garcia Velasco is a recent one. Let me go to the Garcia Velasco. He clearly said that if you give a low estrogen pills for about 12 days, it's all okay. Your success doesn't make a difference at all. And well, the earlier paper by Grissinger did say that they looked at the FSH levels after stoppage of COC. See, after stoppage of COC, if you wait for 5-6 days, you will get menses and you will start the stimulation on day 2. You expect now a synchronization to take place, but actually it doesn't happen. Because after 48 hours of COC stoppage, the FSH starts rising. By the time she gets menses, the FSH is already high for 3 to 4 days and the synchronization is lost. So if you're doing COC for synchronization, probably it's not going to work then endocrinologically. After COC, there is a subgroup of women who will have a low LH. So though the FSH recovers in 48 hours, the LH may not. And LH may take about 5 to 6 days to recover, or it may take about 7 days to recover, wherein your stimulation could be starting. So the follicular growth which will take place because of the stimulation, which will be starting with a less LH pool. And that could be not a very good thing of stimulation protocol. And obviously, estrogen progesterone will be low after the COC withdrawal. What about estradiol? I love the estradiol pre-treatment for most of my clients. Most important is, once you stop estradiol, the FSH will recover in 24 hours. So what I do is I'll give some estradiol, especially when we go for conferences and marriages and ceremonies, when we have to schedule our cases, I'll give Proguanova twice a day. And once I tell the client to take the Proguanova today, let's say only the morning pill, not to take the evening pill, and next day I start my stimulation. So FSH will start recovering, endogenous FSH will start recovering in 24 hours, and you can add up your stimulation, you can synchronize better. The synchrony is better here. With estradiol high, the FSH is quieter. So the waves of FSH is not there. Because there are no waves, there is no recruitment, and synchrony is much better with estradiol. And most important, I feel, is LH is high. And this is so nice. Look at COC, LH will be low, and estradiol, the LH will be high. Because as the estrogen goes up, a chronic estrogen tone in the body will increase the pituitary LH rise, because that's a positive feedback. But this LH rise has no follicle to act on now, because all the follicles are less than 8 millimeters and they hardly have any LH receptors. So this LH is not affecting, but just creating a blood good pool. It's probably giving a good amount of androstenedione for those follicles. So your factory of folliculogenesis is accumulating raw material. So this estradiol pre-treatment is something I love to do it because we get it. FSH is quite in the endogenous, synchrony, and good LH pool. Sometimes people do agonist or antagonist pre-treatment. Like people look at, some doctors are very sensitive about LH. They feel LH is a foe. Believe me, LH is such a lovely hormone. And I'll try to discuss that. LH is, if you ask me, LH is one of the friendliest hormone. A good LH, I'm so happy. So they would use antagonists, and there are protocol like stop agonist protocol, where you do long agonists for some time, from late luteal phase of the preceding cycle. Once the menses comes, then start stimulation without agonist, and an antagonist has a routine antagonist protocol. Or some people also like to give antagonists for 3-4 days and so like hypothetical LH down. The hypothetical LH down is basically because they feel it is a high LH with PCOS, which is ruining the stimulation, but just a cosmetic effect, not going to make any difference there. And I don't use antagonists to suppress anything in my practice. But there could be people who are using it. If you look at the data which is published, there's a lot of data on antagonists in normal responders or in poor responders, but there's hardly any data in PCOS where they've given antagonist started stimulation. But most of us use antagonists pre-treatment to decrease the LH. There are hardly any publications on that particular aspect of the story. But if you used it, your LH will be low, FSH will be low, ovary will be quiet. There will be reproductive hormone or reproductive, I would say, gonadotrophin related hypophysectomy is exact word what you have done by using this agonist or antagonist earlier. Obviously, synchrony will be there, estrogen, progesterone, everything will be good. So I feel I prefer using estradiol pre-treatment, which has a good LH pool to start stimulation. In case you have a low start day LH, what do? You could have that. You could have an LH level of 0.5. Am I recommending you to do LH? No, don't do it. But suppose somebody has taken 3 doses of leuprolide depot, or somebody just withdrawn from OC pills, or somebody has had a poor response in the previous cycles, then you can be a little more cautious. You can do an LH level. Otherwise, routinely, I don't do start day LH at all in any of my clients. But if the LH is less than 0.5 and 1, why I'm keeping this range? Because all these papers were published by Richard Fleming, Roy Homburg, and one more author when GnRH agonist long protocol was used. And all three had a different cutoff. I think Richard Fleming had a cutoff of 1 and Roy Homburg had a cutoff of 0.8. So let's put it less than 1. But if you have a low start day LH, your LH pool is low, less amount of androstenedione are available for conversion of estradiol, so the follicle could suffer and chance of empty follicle is a little higher. And then what do? You don't want to lose the client. What my policy is, I will start Proguanova 6 mg a day for 8 to 10 days. Obviously, as I told you, estrogen pre-treatment increases your LH. So at the end of 10 days, I will do an LH level. The LH level is picked up to 2, 3, 4. Then that I'll start off the stimulation. Anyway, instead of giving estrogen pre-treatment premenstrually, I've given it postmenstrually. And this estrogen is anyway going to suppress the FSH. FSH low, good LH. I've created LH pool and I will start off the stimulation in this particular thing. What about residual follicle? Don't you think it bothers a lot? And we talk so much about residual follicle. I'm going to try and tell you, and this is a slide given to me by Sharyu. And I really appreciate her for this. And she really told us how residual follicle is such a friendly thing. So imagine what happens is when you have an ovulation in the previous cycle, with the LH surge, even the FSH also goes up. This rise in FSH will reach threshold of a few antral follicles and they will start growing up. But believe me, they are growing in a luteal phase. So they should regress on their own. So they'll go toward 13-14 millimeter and they will regress. And this is called typical luteal phase dominant follicle. Gynecologists, we love our short form. LPDF, it's like a SPDP of pruning. So LPDF, typical LPDF, there is a follicle goes over 13-14 millimeter, disappears by the time the next menses. This is but in women who are advanced age or women with a very low ovarian reserve, sometimes this follicle will persist in the early follicular phase of the next cycle. The moment that persists, like you do a scan, you find a 16 millimeter follicle, a hemorrhagic surge, would be 18, 20, whatever diameter, anything beyond 14 millimeter. And that you call a typical luteal phase dominant follicle. So what is it doing? This luteal phase dominant follicle is secreting estrogen and it is also secreting inhibin. And what will estrogen do? This estrogen is not only now, but it has been there for last 5-6 days. So this estrogen is like a natural estrogen pre-treatment for that particular lady, which is not allowing FSH to go up. Okay. And now whatever remaining follicles are there, they are automatically synchronized. So there is no point bargaining or talking a lot about that atypical luteal phase dominant follicle. I feel it is like the God has given you, the nature has given the estrogen pre-treatment and given you synchronized situation. So I love, this is physiological synchronicity. Now, somebody will say, yeah, you give this atypical follicle and you want to do a fresh embryo transfer. Can you do it? Yes. You may not be able to do it if this atypical follicle is secreting progesterone. Very less likely that it will secrete progesterone because by now, She has got menses. If you were secreting some significant progesterone, probably she would not have got menses. But still, on a safer note, just do a progesterone level. If it is less than 1, which will be in most of the cases, start your stimulation. Just don't look at that follicle. Don't even aspirate. No janja, no investigations to be done. If you have a typical LDH, just start with the stimulation. Now, you will say, well, there is a thick endometrium also. Good. That means the atypical LPDF is definitely secreting estrogen, which is acting on the endometrium is thin, and anyway, you can just change your decision to frozen embryo transfer cycle and wouldn't matter much at all. Never in my life have I ever aspirated any of these LPDF to before any start of the stimulation. Now, do I apply the same philosophy when I'm doing non-IVF cycles? Your control ovarian stimulation? I would say yes, yes, yes. I always apply the same philosophy. I will not cancel or hesitate to start a stimulation. I'll just do a progesterone level and rule out a thick endometrium. If there is a thick endometrium, patient has got menses, I'm not going for IVF. That means there's going to be a natural pregnancy. Probably I'll wait for this cycle to go off. But never again, don't use OC pills. OC pill is completely paradoxical for any IVF practice. You find a typical LPDF, just neglect it. Wait for 15-20 days, it will die its own story. There is no need to give any hormonal therapies whatsoever. What about day 6 of stimulation? Vasundara, is it okay? In the sense, everybody's... am I audible? Is there any problem?
Yes,
I can't see myself.
absolutely fine, sir. Absolutely fine.
Because I'm doing an iPad, so I'm just speaking to the host here.
We are all stuck to the chair and totally listening to you, sir.
No, not that. Okay, just a small break was this day 6 of stimulation. I think this is again, all these diagrams are, you need somebody to do those things for you. Day 6 of stimulation, E2 is rising, LH is low. Why LH is low? Because of gonadotropin surge attenuating factor. The moment the follicle starts growing from 6 millimeter or 4 millimeter to about 12 millimeter, this early part of follicular growth secretes this factor called gonadotropin surge attenuating factor. I humbly request all of you to read papers by Missinis et al. On gonadotropin surge attenuating factor. Beautiful papers. He really says that please don't use antagonist at all. You can do an antagonist-free IVF. But I don't want to complicate the issue. I'm just telling you the first day 6, what are you expecting? E2 will be rising. So the follicles are recruited and they're secreting estrogen. Collectively, the E2 is high. LH will be low compared to your day 2 LH level or her basal LH level if done in the earlier cycle. Let's see what happens to the FSH. The FSH is going to climb up every day because you're pumping in FSH injections or HMG injection containing FSH to her every day. And FSH has a long half-life of 36 hours. It's going to accumulate. So every day, the serum level of FSH is going to go up and up and up. The estradiol, which is in the red dots, is going to go up and up and up. But on day 6, there you're going to start your antagonist, isn't it? You're going to start your antagonist. The moment you start your antagonist on day 6, your LH is going to drop down. We're going to study this in the next 2 slides. So in the first, from day 1 of stimulation to day 6 of stimulation, what happens? The LH will drop because of gonadotropin surge attenuating factor, and FSH E2 will go up. Why this is important? Imagine a patient who has given OC pills or leupride depots. Your LH is already low. She's been low LH for 7 days. Then you started stimulation. Whatever low LH, that also dropped further. So for the whole 12 days, 6 days of stimulation earlier, her LH has been very low. This is what I call low LH pool, and this is very bad for any stimulation protocol. So what do you expect on day 6? Expected E2 should be beyond 100 picograms. And LH will be lower than the basal LH. FSH high, but we hardly measure the FSH levels. What about high response? When the E2 is beyond 500 picogram, typically will be seen with high responders, or you are seeing 15 or more follicles which are beyond 10 millimeter. That would say this is an expected high response. You're making a decision, well, I'm going to agonist trigger. If you're not counsel this lady for a freeze-all cycle, I think this is the right time to enlighten her that we may have to go for a freeze-all cycle. What about hypo response? Can you decide a hypo response and cancel a cycle? Or can you counsel the client? You can counsel the client for 1 cycle, but you go for a stimulation on day 6. You see that at least there are 6 follicles which are but all between 6 to 10 millimeters. They're not recruited. There's no follicle beyond 10 millimeter, and E2 is less than 180 picogram. But then this could lead to a hypo response. It could be a longer stimulation. You may have to do additional drugs. All those juggleries and jugards will have to be done here. But believe me, all these cutoffs are on long protocol, and there is no data of defining hypo response on the ANTA protocol. So we are just replicating this in our antagonist and thinking that, well, that could be true. But at least it gives you a little lead whom to counsel that where I'm expecting less follicles, stimulation could go longer, or I may have to tell them, you may require one more cycle, etc. It's all those decisions can be done. So what day 6 decisions are very, very individualized. If there are no follicles beyond 10 millimeter in normal responder, or if there are 2 follicles of 10 millimeter or more, you can step up the dose. So this can be done. Now, stepping up the dose is something which I really, really dislike. I don't want to do step up the dose. I better start full throttle stimulation on day 1. So no stimulation, I start less than 300, maybe sometimes 450. So I don't have to do an intersect, because in between, if you do a step up, I don't know how much hardly it will contribute to anything. And if you go by the paper by Tilburg et al., who published on low dose for low responder clients, and the client also about 52% of the patients required a step up of the stimulation. I think that is something I don't desire, because what happens is you're just recruiting one more herd of follicles, and that you're increasing a lot of asynchrony by the time you come to a trigger day. So better start a higher dose earlier rather than stepping it up. If no follicles beyond 10 millimeter in PCOS, well, that can happen. You can have somebody who has a very high AMH, you start at 300 IU, but instead of giving 6-7 days of stimulation, all follicles are gone. They've gone from 4 millimeter to 8 millimeter. They're not beyond 10 millimeter, but they're growing. Because the AMH is offering a lot of resistance here, the follicle growth will be slower. They may take longer stimulation. In poor ovarian responders, where AMH is low, there's no resistance to your stimulation. FSH is going to kick off very fast, and the follicle will be rather 12 millimeter and 14 millimeter on day 6 of stimulation itself. But PCOS can have, you don't make any alterations in the dose, just continue the same dose. E2 less than 100 picogram, and there is no recruited follicles. You've gone to day 6, E2 level comes 70 and 80, and no follicle is beyond 10 millimeter, just abandon the cycle. Because if you now step up the dose, your stimulation is for 12 days from today. So she's already taken 5 days. Now today is as good as your day 2 of the menses, and you're starting your stimulation for 12 days from today, and that's really going to be a whole of increase in the post-operative treatment, counseling, etc. And if you give an early trigger, etc., you'll end up getting very less follicle output. FOI will be very, very low. LH level during stimulation, good LH level during stimulation, better the outcome. During the whole course of stimulation, you should have a very decent LH level. I would say between 2 to 10 anytime. Even if the level is 13, 14, 15, 17, 18, 20, it's all okay. If you have an ulta, over suppressed LH, that is the one where there will be poorer outcomes. So this is a beautiful paper, a 2023 publication by Pang et al. They talked about the LH level on the antagonist administration day as a predictor of reproductive outcomes in women with normal ovarian function. Can LH on antagonist day, antagonist start day, I should have said that, day 6, be a predictor of clinical pregnancy outcomes? See, beautiful result. Look at that. So look at the graph on the left side. They are talking about the number of oocytes retrieved on the y-axis and LH on the antagonist administration day. See, there is a gentle high. That means as the LH level on the day 6 of stimulation is higher, you have more oocytes you get. And look at the blastocysts obtained in the right-hand graph. Again, significantly high number of blastocysts, provided your LH level on the ANTA start day is good. So women with extreme poor reserve, advanced stage may have a higher LH, maybe 8 to 16 MI on start antagonist. Don't worry about it. You're still going to go. It's very logical here. If your machinery, your company has to do well, your raw material has to be good. Raw material in our follicular genesis is androstenedione. A good LH level assures you a good androstenedione, hence good raw material, hence your estradiol production will be good. Estradiol is a mitogenic hormone. It will cause good amount of proliferation of the follicles, and the follicle will grow better and better. Now, LH levels may be used as an indicator of time of antagonist administration, generalized antagonist protocols. This is a proof of concept study published by Liu et al. From China. In this study, they said, sometimes you want to be flexible and we want to have a flexi LH. You really don't know what criteria we should follow. I love this study, the way they put it up, and this is worth replicating in our scenario, and you can have an individualized approach of starting antagonists. Only thing is, in this particular study, you have to call the client very frequently to do their LH levels, maybe an alternate day. So in this study, if LH is less than 4 MIU, in group A, they did not add antagonist. In group B, when the LH level is beyond 4, they added an antagonist. And clinical pregnancy rate in group A is 69%, and group B is 54%. So what they say is, if the lady already has a persistently low LH, less than 4 MIU on day 6 stimulation, on the start of antagonist. Adding antagonist will take it much lower and the outcomes will suffer. So again, coming back to the same story, a certain amount of LH is necessary. Low serum LH levels during ovarian stimulation with antagonist protocol decrease live birth rate after fresh embryo transfer, but have no impact on freeze-all cycles. And this is published in 2021 in the Frontiers. This is again a Chinese study. So again, low LH affect fresh embryo transfer, also cumulative live birth rate when you have fresh and frozen together in CLBR calculation. But if you are only calculating the frozen embryo transfer, there is no effect in the first frozen thaw ET. So they're thinking that is serum LH a biomarker of good COS cycle and result. That's very important. I think this we should take it to the heart. So maintaining a good LH level will be good. And LH receptors are also there in the endometrium. So I think there is maturation of the endometrium could also be better here. What about antagonists? Let's understand the antagonist action kinetics. LH very high on anti-day. Let's say you do an day 6 LH and comes 13. Okay, so you're worried. What you can just start an antagonist, it will drop down in 4 hours, 2 to 4 hours it will drop down. After 4 hours, the antagonist action wears out. About 12 hours or something starts coming up. By 16 to 24 hours, it has recovered. Now, but you go for 2 days. After doing 2 antagonists, you repeat an LH level before the 3rd antagonist. You want to know your LH is suppressed. And believe me, LH will be nicely suppressed and you'll get good outcome also. So antagonist action gets stabilized after 2 days. So you can do a repeat LH afterwards. But this is very important. If you, there would be a subgroup of women where the LH level does not recover to the 50% of day 6 level on after 1 antagonist. Let me just clarify again. Day 6, patient comes, we do an LH level, give antagonist. Day 7, the patient comes. Just allow me 1 minute. Darki, I'm going to call. Can I call? Unless it is urgent. Yeah. I'm so sorry for this. So you do day 6 LH level, then give antagonist. So you have a day 6 LH, let's say it is 7. You do antagonist. After 24 hours, the client comes home before taking the next day antagonist. Again, do an LH level. Now, this LH level is 1. That means it is not even recovered to the 50%. But this particular patient is going to maintain a low LH level through the next part of the stimulation, and addition of LH activity now will make her good. Do we do this? We don't do this routinely. If you're using HMGs and things like Menopure, and you're not using RFS alone in stimulation, this is something which can go on without any changes. Now let's come to the trigger day. Trigger day hormones, what trigger choice, OHS prediction, freezing decision, etc., etc. Okay, this is a paper on prediction of early to moderate severe ovarian syndrome, OHSS, in non-polycystic ovary patient. I think this is very important. Polycystic ovary, you've already taken a decision to give agonist, trigger, and freeze-on. So what about the non-polycystic ovary patient? So they say that if the estrogen level is beyond 2000 picogram, if they're beyond 17 follicles, beyond 12 millimeter size, then your area under curve is almost 0.95 with that E2 levels. That means this is pretty significant. There is a likelihood of OHSS. So estrogen level goes high, you can think of changing the decision to your agonist trigger and going high later on with freeze-on for non-polycystic ovary syndrome patients. In PCOS, if the E2 is beyond 4000 picogram, beyond 20 follicles or beyond 11 millimeters, we generally don't give HCG, but we prefer going for this. Poor at risk, patients with hypothyroidism, estradiol is generally more. Low thyroid stimulates FSH, LH because of low thyroid, TSH will be high, and TSH and not only TSH, even FSH, LH also goes high. So innately, these clients have more E2 levels compared to the non-hypothyroidism, and low BMI also will have low estrogen levels. What about progesterone elevation on the trigger day? Now, this is entirely depends on the response to stimulation and the number of follicles recruited. If you give a very faster stimulation, higher doses, more use of recombinant FSH, even with HMG, if the stimulation is faster, a large number of follicles growth, obviously you're going to have the progesterone levels going up. It is non-LH progesterone level, which is not LH because of LH, which is because of an internal story of 2-cell to gonadotropin theory, wherein you have an androstenedione, but your aromatase is not able to convert everything into your estrogen. So there's a back pressure which causes pregnenolone and progesterone to increase in the theca cells, and that progesterone enters the circulation. That's why the circulatory progesterone goes up, and that can affect the endometrium. We all know that elevation of progesterone will affect fresh embryo transfer results, but we don't know the cutoff of progesterone, okay, or because we don't measure the trajectory, we just measure 1 point, a snapshot of progesterone. So these are all older studies. The moment we have shifted to freeze-all, we hardly do any progesterone studies on that particular day. In poor responder, less than 1 nanogram also can have, the Vanity study of 60,000 patients of IVF on fresh embryo transfer patients, they said that between 0.8 of progesterone beyond on the trigger day can affect the fresh embryo transfer results. Normal response about 1.5 and above. High responders, because they are high amount of estrogen, the endometrial hyperplasia is there, and just 1.5 progesterone may not be able to change the results. You require a higher progesterone to change the decision for not to do a fresh embryo transfer cycle. But this, I feel, is a older story. We hardly do these things nowadays, and many times simply taking a decision for frozen embryo transfer is okay, unless you have a poor responder and they want to go with the fresh embryo transfer cycle so that they can save on the money and time, etc. Well, this could be that. But do we need to really measure progesterone in oocyte donation cycle? Oh, something so different, isn't it? Why the hell, oocyte donation cycle we should measure? I feel when you have a progesterone going up, that means your machinery of 2-cell to gonadotropin is perfectly working at its peak, maximum speed achieve किया है. So, अगर आपका progesterone बढ़ता है, the progesterone is going up, that means you have achieved the peak and no more, the machinery can't work anymore. That means the whole stimulation is working at its perfectionist and you are going to get more mature oocytes. So many times it happens in a oocyte donation cycle. After 10 days of stimulation, my monitoring person says, well, the follicles are touching 17, 18, should I give a trigger? I said, do a progesterone level. And they said, well, progesterone is 0.3. I said, just give me one more day, do it tomorrow. Next day, they said, progesterone is 0.9. Okay, I said, fine, give a stimulation today, give a trigger today. So higher progesterone on trigger day, you will get more into M2s and more embryos are there. This is a beautiful study. You can go through this very quickly again. Serum progesterone level affects the outcome of IVF patients in different ovarian response. This is an analysis of more than 10,000 cases. And look at that. What it says that as the serum progesterone level goes up, the endometrial effect is also there. But it is, your ongoing pregnancy rate comes down. Because this, but as the serum progesterone goes up, look at the better oocyte. The better oocyte quality improves and improves. So should you do it? Okay, from the oocyte point of view, you can do it. The endometrial, if you're taking a freeze-all decision, still you can have a talk, decide on the oocyte quality and better this. Both high. This is a very difficult paper to understand. Let me just tell you. I would like all of you to read this paper and give some more insights to me as well. Both high and low HCG progesterone concentrations negatively affect the live birth rate. What they looked at is progesterone as a continuous variable, and they plotted rather than dual variation. They looked at the continuous variable, and this is a prognostic model with a progesterone on HCG day as a predictor. They tried to develop in this particular paper. And look at the square there, and look at the left side diagram and the live birth rate on the y-axis, the progesterone on the x-axis. Even if the progesterone is very, very low, your live birth rate is low. And in that box, and you go beyond, if the progesterone is high beyond a certain level, the live birth rate is low. So we know about the story on the right side, but we don't know about the story on the left side. So this gives an information that, we don't fine-tune your IVF cycle so much, but even if the progesterone is very, very low, the live birth rate is going to be. So both low and high progesterone level on the day of HCG can affect live birth. The problem in all these studies is when to do progesterone level. It must be done early morning. It must be done at 8 o'clock only. You can't be doing an evening progesterone level and saying because there is a progesterone variation, diurnal variation. So you need to put up a program of doing hormonal tests in your IVF laboratories. Should you measure trigger? HCG trigger, we don't measure as a usual practice. Agonist alone, you should measure. I measure all my agonist alone triggers, and dual again, I don't measure. So this is if agonist trigger measurable. The LH activity will go up in about 4 hours. It generally goes to about 60, 80 IU as well. In the first, when it touches about 20, the maturation will take place, but the ovulation takes place very high. And it starts coming down in about 20 hours. So by another, I generally give to trigger at 12 hours later, I see. What am I going to see? I'm going to see still the LH levels high, then declining down, but not come to the nadir, and I'm seeing the progesterone levels go up. So, but I can't be doing an LH level after 4 hours because it will be midnight and getting the client back will be so difficult. So this is typically seen LH high and progesterone also high. So generally the demarcation is if your LH level is less than 15, or if your progesterone level is less than 3 nanograms, you can't think of a retrigger, or your trigger must not have acted very well. That's the time you start suspecting that. Circulating luteinizing hormone levels after triggering oocyte maturation with GnRH agonists may predict oocyte yield. Okay, in the flexible. So look at that, what they have done. So they gave the trigger and they looked at the levels and the oocyte yield on the y-axis and the serum LH levels. The moment the LH level is beyond 15, your oocyte yield is better and better. Okay, but if the less than 15, the oocyte yield is low. So I think that's why measuring a trigger could be again good to sensitize our clients. 12-hour post-agonist trigger LH level less than 15 is associated with lower oocyte yield, but not with maturity and fertilization. The oocyte yield is only low. Serum LH level post-trigger with GnRH agonists do not affect clinical outcome. Because at the time, if you're transferring one good blastocyst, whatever trigger you're given, your pregnancy rate could be still good. What about assessing adequacy of gonadotropin releasing hormone agonist trigger in oocyte maturation and management of inadequate response? This is a study earlier by Kamar et al., Chen, Mayer et al. LH less than 15, this was associated with less oocytes. Progesterone level is complementary to LH. Higher the number of follicles, obviously more will be progesterone. Progesterone above 5.5 and LH below 15 can obtain a good oocyte, but progesterone less than 3 and LH also less than 15, they may not obtain good number of oocytes. What about PPOS? How do we do endocrine monitoring of PPOS? And this is a typical PPOS. On day 6, we hardly do tests. Unless it's a flexi PPOS, I'm going to take your decisions accordingly. Day of trigger, you can do an LH and E2. Well, we can't obviously do progesterone. We're not going to interpret that. And if agonist alone it trigger, see, the first paper by Kuang et al., and when they looked at the agonist alone trigger in PPOS protocol, there has been an attenuation of the LH rises there. So most of the papers published use a dual trigger. They use agonist alone as well as a small amount of HCG like 1500. But there are adequate number of PCOS papers in PCOS patient where they're agonist trigger and they got a good yield. I think it's not paradoxical, that is physiological, because in PPOS you have such a large number of oocytes. I don't think an attenuated thing can affect much when it comes to the outcome, the clinical outcome of the client. So if you have PPOS, if you have segmentation of IVF cycle, you're doing, we all do segmentation while you do the pickup first, ICSI, etc., and the transfers later. If you have a good ultrasound monitoring and you're doing random start, probably a very strict monitoring is not necessary. We do rather nowadays we do more hormonal tests in our FET cycles than our other cycles. What about ovarian stimulation and ICSI guideline and the Cochrane? What does they say? Addition of estradiol measurement to ultrasound monitoring is probably not recommended. And addition of hormonal panel consisting of combination of estradiol, progesterone, LH measurement to ultrasound monitoring is probably again not recommended. So nobody is guiding us that way, but still we do it as a consensus-based practice. But we are enjoying the current practice of reproductive medicine based on scientific data published, which was conceived after a lot of hormonal monitoring. That's how the scientific data ever came into publication. Counseling for unexpected poor response monitoring is helpful. Hypoc IVF stimulation, this is useful. For second cycle, how will you do your second cycle? Like, herein, I even do FSH level on day of trigger. Let's say this patient goes ahead and she gets only 4 eggs. I was expecting 12. But if the FSH level on day of trigger is beyond 20, that means my stimulation dose is perfect. Beyond 20, there can't be any more recruitment of follicles. So that's a peak FSH level. All your FSH receptors on the follicular pool is satisfied. So you can convince your patient, well, I achieved a correct FSH level, so there's nothing objectionable to my dose. You responded poorly. That's what it is. Hormonal monitoring, complementary for cancellations, dose administration, and freezing on the go kind of disease. Well, thank you so much, all of you, for this patient hearing. Thank you very much.
Thank you, sir. Can you just turn on your video, sir?
Yeah,
this was such a wonderful revision of our basics and also day-to-day practice. So I would I think from the beginning, sir has taught us, what is this AFC tracking? And instead of random start, it is such a useful, point sir has mentioned about AFC tracking. And whenever you find a synchronous follicle, you can start. So that can be a random start thing. And then he also mentioned about luteofollicular transition, which is, in poor responders, what to do when there is a 13 millimeter follicle and what is the ideal protocol, and what about, pre-treatment strategies to, synchronize the follicles, especially when we are doing antagonist protocols. And he was talking about follicular antagonism. One very interesting word which he used is gonadotrophin related hypophysiectomy. I really, it's a wonderful point there. And also he was talking about gonadotrophin surge attenuating factor. We all should definitely read that Messin's paper which Sir was mentioning, and we will also like to forward that. And all of us are definitely worried about the dominant follicle which is there. And Sir beautifully, told us it is a physiological pre-treatment, and it is a point to really think about and use the physiology and, kind of stimulate our patients and not to worry about that dominant follicle. And there are so many questions there on the chat box, sir. So, but I would like to, kind of start off with asking you, what do you do? Actually, most of us are into antagonist protocol and we don't find that much of a synchrony in our follicular development. So in your practice, what do you generally do? Do you routinely do pre-treatment estradiol for all your antagonist protocols, or how do you kind of achieve the synchronicity?
Yeah, let me tell you, very few cycles I start NEEM on day 2 or day 3 of the patients. Okay. Even if I'm starting on day 2, day 3, they are always pre-treated with estrogen at least for 7-8 days with Proganova 2 milligram, 2 twice a day, or sometimes 3 times a day. And otherwise, most of my low responders, whenever the AMH levels are low and when I'm seeing follicles less than 16 inch ovary, I just tell them, okay, I'm going to look at your ovarian cycle and I'm going to find out a right time to start your stimulation. Okay, so I just call them every 7-8 days, and generally in the late luteal phase, I pick up, I say, well, I'm happy today and I'm going to start up. Let me give you one example, anecdotal example. So this patient, I think Sharyu was doing this, and we went with an IVF cycle. We were not expecting a large number of eggs. There were about 5 eggs on each, 5 eggs on each side. And we just obtained one egg, one egg and one embryo day 3. We didn't have guts to go to blastocyst. We stopped at that and froze that. And we told the client, well, on day 5 itself, we are not going to go for blast and we are okay with whatever we got. We may have to go for one more stimulation. I request you to come again and again. So she came after 15-20 days, and on that day, suddenly we saw about 8 to 9 follicles on either side. And I said, though you're not mentally prepared to start off the stimulation, let's start off today. And believe me, we got 9 oocytes and we could have about 3 blastocysts developed out of it. So why this happened? What could be a physiological explanation? So what she was maintaining is some kind of an LH-FSH tone. During the previous stimulation, we increased the FSH levels for about 10-12 days, and that remained in the body. That increase in the FSH recruited a few more AFCs, and which were takeable for us in our next stimulation. So many times I use this policy also in patients with hypo. You start with 150 IU-HMG, take it for 30 days. So, we are maintaining a high FSH tone. With that high FSH tone, a lot of follicles will grow. At the end of 30 days, you see, even if a follicle ruptures in between, that's okay. She may achieve natural pregnancy. Even if she doesn't, at the end of 30 days, your AFC is different. And then you can take it further. So, I don't do day 2. Maxima are not that way. It is always random. Random is a very fallacious word. I would say appropriate day starts stimulation.
And that is the beauty of using estradiol, valerate, and
Absolutely. Okay. I never used an antagonist in my life to synchronize anything.
So many times
I'm quite critical about it. I humbly apologize for that, but I'm very critical about it. There are only 1 or 2 papers, though they have reported good results, but they are on poor responders and this. You don't bother much about it. Just start off.
So day 2, day 3, day 4 antagonist is not going to really help with anything.
It is my opinion. Again, humble appeal. I know it's a practice. This is not a forum to keep arguing on papers and those things. But it is my practice, my way. Your way could be different. I respect your way also.
No, definitely, sir, because you told us about how that LH pool is definitely important for us.
I feel so.
It is really that wonderful take-home point. So what we just wanted to ask, most of us are following a fixed antagonist start protocol. In certain scenarios, we do encounter hyporesponse, or when there is a low E2 or something like that. then what do? We have to monitor and, start the antagonist at an appropriate time. That is one thing. And other thing is, sometimes you monitor the LH levels and they're really, really low in certain situations. Even in sometimes, I've seen on the day of start of antagonist, the follicles are good, but the LH levels are very, very low. So whether it's something related to the polymorphism, I really don't know. So you have encountered such things, and what is your,
You just see, if you have a decent pool of follicle, let's say anything around 10 follicles, 5 on each side, and you are having good amount of GNSAF. So that high GNSAF which is going to grow, and that will suppress the LH. We don't know who will get more suppressed. These are individual variations, and we would find somebody, LH is 4 at the start of the stimulation, it could go to 0.2 on the day of antac start. I'd like to add an HCG here. I'm not in a very big advocate of making the HCG and do the jugaad and give the 100 IU, make one and put the 10 IU करो. वो जुगाड़ मैं नहीं करता हूँ. मैं simply menopur use करके खत्म करता हूँ. So, for scientific, I just use menopur. I'm happy about it. Rather than another client is not affording. That's an economical question. We are discussing science and not economy. Economy can be debated and that can be discussed. So one can use HCG that way. But then this is what I would say. So I had this client. Let me give you an example again. This client was it was a surprise low LH. I still don't know why she has low LH. Normal FSH. She's developing follicle. LH level has been 0.2, 0.3 all the time. मैंने MRI किया, DAS study किया, सब कुछ किया, but I could not find out a reason why this LH was low. So I request, and the AFC was hardly 3 or 4. She was a patient of adenomyosis and endometriosis. So I requested, I would like to give you a HCG for a little longer time. So herein I did that jugaad, getting a 2000 IU ampule, diluting it and giving every day, 200 HCG on alternate day. I gave it for almost 15 days. The AFC improved, and then I went with an IVF, and now I have about one blastocyst and I have two day three embryos with me. I've requested them to go for one more cycle, and then probably I'll think of transfers and things like that. So some situations can happen, but if you have very low LH, menopause comes as your savior.
So there are situations
there used to be an overtrill pen, but I don't know, the Merck people have taken it away. But the overtrill pen issue, it gives 500. The dose is quite high still.
Yes, sir. So
but you can use it alternative.
There have been situations where, we are giving antagonists and then the LH is very, very low. And then on the day of trigger, if it is too low and it's a hyper responder, you don't want to give a HCG trigger. So there are some days where we skip the antagonist and then, allow the LH to recover, monitor LH that way. So
I don't know. I don't think that's again cosmetic. I feel, and we are too much guided by that 0.2 LH. If your stimulation is having a combination of RFSH and HMG, of any HMG, HP, HMG, or recombinant LH or parvovirus, whatever, if you are maintaining an LH activity right from the beginning through your stimulation, you don't bother about what is the day LH level on the day of trigger, because all these HMG, as they start getting purified, the LH is lost. So the manufacturer has to add some amount of HCG as a LH surrogate. But we don't do HCG levels, isn't it? Suppose the HCG level we do, and it comes 3.5. Okay, 3.5 means 3 sevens are 21. 21 is the LH level. So we won't be worried. So if you streamline all your stimulations with a combination of RFSH and menopur, believe me, you will not face any issues. Because फिर hormone का सवाल नहीं आएगा, the HCG activity is there, which is beautifully there.
So can I ask one question? So across responders, why not we just use HMG, LH activity, and why stop monitoring?
My next talk is on that. My next talk with the verdict group is going on with the ferric conference is on that LH only. So that's what I highly recommend. I would say I do agree. Menopur is expensive. There's nothing wrong in using HMG. What Indian jugaad you can do, if you don't want to use 300, use 450 IU. Even if the HMG of a little poorer quality, with 450 IU, a certain amount of FSH activity will be delivered to your client. Because our clients are difficult, our clients are obese, our clients have accumulated cardiometabolic problems for a long time. And when cardiometabolic problems accumulate for a long time, it does affect reproductive endocrine system badly. So the resistance is more. So you can increase the dose safely. And don't worry about OHSS. Agonist trigger hai na.
Yes, exactly. So a few questions on the chat box. I think you've answered this. How many days of estrogen pre-treatment do you recommend?
Depends upon when I want to go to a conference, when is my party, and when is my marriage ceremony I'm going to attend. So it all depends. Doesn't make any difference. You give it for 10 days, 20 days, 30 days, whatever. 30 days, so nobody will give. I'm just joking that. But anything around whatever reasonable, I've given it. So let me come to evidence. There's a beautiful evidence published by the Spanish group. I think this has been published by Polizos or Garcia Velasco. I don't remember very well. No, sorry, I made a mistake. Not the Spanish, the French group. This paper has come from Lille, France, and this is published by none other than Didier. In their university, they always give estrogen pretreatment to all the patients so that they don't want to do any pickups on Saturday. Okay, so now you have a group of patients who have received Progainova for 1 day, 2 day, 3 day, 4 day, 5 day, 10 day. You got it? And they said there is no result difference. So please don't worry, you use it. That was a very beautiful paper.
I think we should read that paper because the next two questions are like, what is the maximum number of days you can give estradiol pre-treatment, and whether menstrual cycle is important? Is this we have to wait for the cycle?
You have to put in our patient's head. कि madam, वो menstrual cycle के पीछे लग के we are ovarian really cycle, harming you. Yeah, this ovarian cycle. My aim is your ovary follicles. My aim is not your endometrium anyway. So that has to be counseled on day 1 of IVF. So what I've done is I've made videos in regional language in Marathi. Why ovarian cycle is important. I just tell them go to the video.
This awareness is very important, sir, because it's been always like day 2 of period stimulation, day 2 of periods of stimulation. So I think, does constant low level of LH affect oocyte quality?
Definitely, yes. A big yes to that. That's what I showed in those 2 graphs. Yeah. It was a nice analysis done. If you keep a higher LH level through the stimulation, your follicle quality, blastocyst, top quality embryos are better, and you can more likely to do fresh embryo transfers as well.
Sir, does the concept of LH threshold value and ceiling effect still exist?
Yeah, LH threshold exists a lot. LH ceiling also exists. LH threshold and LH ceiling, these 2 concepts exist on the start day of stimulation. Because you have to have a certain amount of LH to start the stimulation, that I told you. But you also, if your LH is beyond the ceiling, so ceiling is more than 10. If the LH is beyond ceiling, that means there is increased amount of androstenedione. And you will require a higher aromatase to convert that androstenedione into estradiol, so your dose of stimulation will be higher. You have taken a decision to stimulate with 225 to 300, your LH on start day comes 14. And this patient has always had a high LH. Your stimulation goes to 450 IU because you need to use more aromatase. So on the start day, the concept of threshold and ceiling, very, very important. During the stimulation, there is nothing like ceiling because we use Menopure. With Menopure, the beautiful study, I'm going to put this in the next presentation. You have HCG levels going to about 4 to 6 MIU. 4 to 6 MIU of HCG in the serum level in a stimulated cycle, when 6 sevens are 42. Oh, my maths is good. So 42 IU of LH. 42 IU of LH, and they're claiming you get better live birth. So there is no ceiling, nothing like LH ceiling during the course of stimulation. You just look at a factory. Something is coming in. What is coming in? Androstenedione. Something is going out. What is? Estradiol. Aromatase is what you are inducing. If you are assuring a good androstenedione supply by any amount of LH activity, you are done wonders.
So what is the cutoff of follicle diameter and NH level to start the antagonist in IVF cycle in poor responder patients, especially with a baseline LH of 2 to 8?
Yeah. This is a very, very tricky. And whatever my answer would be, and there would be a lot of variations in answer from different consultants, depending upon individual things. I'll tell you how I understand my story. I understand that if the follicle goes 12 millimeter and above, okay, there is an antagonist is required, because in a patient who is a poor ovarian reserve, she will have less GNSAF. So beyond 12 millimeters. So everybody says 14. Why I'm saying 12 millimeter? Because in poor ovarian reserve or advanced stage patient, the number of granular cell layers among the oocytes are less. There should be about 10 to 12 layers. But in these patients, they could best have about 4 to 6 layers with less number of granular cells, because they get early periods also. They get period at 21 days only, because there are no hardly any granular cells to make luteal cells to make progesterone. They get early periods. So since the granular cell pool is less, they have less GNSF, because GNSF comes from granular cells. So they are going to have an early premature rise of LH. So you add your LH antagonist at 12 only if you're doing flexi. E2, I go by spironolactone, 200 picogram of estrogen beyond 50 hours, premature LH can take place. E2 beyond 200, I get jittery and I can add an antagonist. But lately I'm being, after reading all those papers, I'm playing around a bit. Especially I'm playing around with LH levels by the Chinese paper. If it is less than 4 MIU, I just don't add antagonist. I add antagonist lately, and now I've shifted to elagolix. So injection will band ho gaye. Just 150 milligram, one tablet. 3-4 दिन the client takes tablet, she's happy, I'm happy. Maintaining a good LH level, I'm through. But this is individualized. I can't give a protocol for this.
So in PCOS patients, can LH level on the day of stimulation help to assess the dose of HMG?
Yes. Higher the LH, higher the HMG.
Just now you said.
And there is no difference in RFSH and HMG. You just use, you should use HMG, no doubt about it. RFSH alone is quite inadequate.
So I think most of us now have a lot of evidence now to say that, HMG is very good even in hyper responders.
No.
When
HMG
we just
HMG is the only drug for hyper responders.
Exactly. So the thing is, many of us, think that FSH has to be used, RFSH has to be used in PCOS patients. The risk of premature progesterone rise, what is this thing and the quality of oocytes,
Let's dissect this up. I feel every stimulation in India must have RFSH and every stimulation in India must have LH activity. Okay, so all my stimulations are combo. With the patient say injection jada ho rahe hai, I will take parvovirus. So that's the only combos I get. Or menopure, one of them they will do either menopure or parvovirus. Otherwise, all are RFSH because there is no, our job as consultants is also not to have posidone 1. So how will you avoid posidone 1 if you use RFSH and LH in first stimulation? So what is the treatment of posidone 1? Use RFSH and LH in the next stimulation. Why not use it in the first stimulation? Okay, so that I don't think much about it. Just use RFSH, LH of any source of your love. You can just use it up, and that's what I prefer doing that way, going with the stimulations. And using RFSH for first 5 days and then using HMG for the next 6 days, I feel it's mixing apples and oranges. Never do that. Use it right from the beginning.
So, what kind of monitoring do you do, sir, in your practice in antagonist cycles, typically?
I would like people to replicate my monitoring because I do quite intensive monitoring. Not that every monitoring aspect I change my intent of decision making does not change much because I do FSH, LH, progesterone, E2 for every patient in every visit for 3-4 visits because this is just we are collecting data. So retrospectively, if we are able to publish something, that's the way.
Because I also do too much of LH monitoring, but though the evidence says that you don't have to monitor antagonist cycles.
No, but I do a lot of monitoring. And that helps me in a way that it gives me an FSH trajectory. It also helps me look at the LH levels and add ANTA sometimes little early. Also nowadays because I'm using elagolix orally, it gives me help also whether elagolix is acting effectively in my patients. All those things makes a little easy. So I do monitoring quite a bit, but I don't want to recommend to people that you do it this way. But at least on day 6, you can do an LH and E2. And on the day of trigger, you should do progesterone E2. There you do an FSH level because that certifies retrospectively that your stimulation was good. Otherwise, patients are there to criticize you anyway, and your colleagues will also criticize. So if you have an FSH level reached at a very good level on day of trigger, that means at least you are certifying yourself that your stimulation was correct.
That is a wonderful point, sir. Thank you. So, and this one, like as you said, LH levels, we might have to start antagonists a little early on day 5 itself in some PCO patients.
Yeah.
So,
yes, you're right. Yeah, it can.
So you use elagolix now, sir. What is your experience in using it?
Don't ask me much. Don't ask me much on that. I've just started using since the time it has been introduced. I don't know why.
Starting it on day 5 or day 6 or?
No. The elagolix I'm starting on day 7. I'm monitoring the LH level now. Only if the LH starts going up, let's say goes to 8, then I'll put an elagolix. Otherwise, if it is maintaining 4, 5, 6, I wouldn't bother. I will just do one more day of stimulation and look at that. See, again, we always remember that premature luteinization was a story of yesteryears. We understand it differently. Let's say the LH level goes to 20 during the course of stimulation. But if you recognize it and control it, it's not going to harm you anyway. So rather, it has created a good androgen pool. Happy about it.
So elagolix, when you're using 8 and then you give elagolix next day, you
Okay,
again monitor
one
FSLH,
minute.
sir?
May I request you not to ask me more questions on elagolix? Why? I'll tell you. Well, my own experience is very, very limited. I'm also developing my
No, I
strategy.
understand. So there was
Yeah,
a
give
question
me
on the
some
chat
time.
box.
Give
So
me,
I just
so it'll look very overconfidence on me. Ki ye karo, wo karo. I don't want to do that, and I don't want to people use it unnecessarily and get into problems also. I do intensive monitoring. I can only say I do very calculated intensive monitoring. That's why it is. So let's give some time. Let's give 2-3 months. Let's use it a little more and then come out with some data or some confidence. I don't even have much confidence to speak on that. Let me be very humble that I don't have all
sir,
that.
sure. Totally understand, sir. Totally understand. I think sir has been, talking exhaustively. We have some quiz questions and some polls at the end of the session so that, we can summarize the whole thing. Sir, at the outset, we would like to extend our heartfelt thanks and gratitude for the wonderful, wonderful lecture and teaching today. It has been immensely useful for everybody over here, and we would request all of you to please share your feedback, and also already so much overwhelming feedback is there in the chat box. Thanking you, sir, for taking this 1 hour time of yours. It's like extremely precious for all of us. Huge respects to you, sir. Thank you so much.
Thank you so much. Nice of you. Thanks for the invitation. Thank you very much.
And we will definitely would like to, invite all of you for this part 2 of the session, which will be happening on 22nd of May. Details, we will share it with all of you soon. Thank you so much, sir, for accepting. I'm sure we'll be joining you in the subsequent lecture, which you're going to.
Oh, no, I'm still looking at the PPT. Wait, I requested Sachin to take it over because I'm still looking at the PPT.
Sindhu, can you please share the poll questions and quiz questions before we.
Vasundara, can you allow me to leave if you don't mind?
Sure, sir. Sure, sir. Thank you so much. Thanks so much, sir. Thank you so much. It was really wonderful, sir. Thank you so much.
Thank you.